Good morning and welcome back. Thank you so much. So this is now part 3 of our series on the frenuloplasty topic. The first couple of lectures introduced sleep disorder breathing in general, and then we looked a closer look at tongue tie, appreciating how tongue tie is only one part of the bigger picture. And we went over the evidence relating to how tongue tie affects sleep and breathing. And what we learned is that tongue tie is most effective when it's coupled with myofunctional therapy. And this is the systematic review and meta-analysis that we demonstrated, showing that myofunctional therapy can reduce the apnea-hypopnea index by 50% in adults and 62% in children, with important role in preventing relapse. And we talked about the fact that the goals of therapy are to get the lips together, the tongue up on the palate, and only nasal breathing. And where tongue ties come into the picture is that structural restrictions, such as tongue tie, can interfere with the goals of myofunctional therapy. At the end of the lecture yesterday, I introduced that some tongue ties are obvious and others are not so obvious. And in this lecture, we're going to focus a little bit, half of it on diagnosis and half of it on the management of these tongue ties. And so I introduced the Kotlow-free tongue classification, which assesses the length of the tongue from the insertion of the frenulum to the tongue tip. Okay? And this classification was developed in ages 18 to 14 months, primarily looking at speech and swallow indications. And so if you look at this classification, you have someone who is 6.5 millimeters from the attachment to the tip, and that's severe ankylosing, and we might agree. But if you look at someone whose free tongue length is 15 to 17 millimeters, this would be classified as mild to normal. And so the problem is if we're doing research and we're drawing the line right here, you're not really going to see a difference between this one and this one. So what we're doing is we're saying that, tongue tie is an important issue. We're appreciating that when it's very, very severe early on in life, it can affect swallow and speech issues. But if it goes undiagnosed, it may affect the development of the maxillary facial skeleton, contributing to a narrow, high-arch palate, and that'll set you up for nasal obstruction and sinus issues. And if that perpetuates, you may get problems with obstructive sleep apnea later in life. And so here we are in a quandary where you have this 6-year-old girl who has sleep and breathing issues, and we're looking to assess whether or not there's a tongue tie. And so we're quickly appreciating that the structural definition, the free tongue length, is inadequate to describe this functional ankyloglossia. And so what we did with Dr. Audrey Yoon is she examined 1,052 patients, and we went through the literature and identified every single kind of manner that we could evaluate a tongue mobility. And we determined, based on our research, that the tongue range of motion ratio, which was developed and talked about in Dr. Mark Hassan's work, is one of the most powerful for describing variations in tongue mobility. So we're looking for a scale that will give us vocabulary so that we can describe when the tongue is very tight and when it's not so tight. And so the way that this works is it focuses not on the length of the tongue, but rather on the mobility of the tongue. And so what we do is we assess the maximum mouth opening, and we assess the opening with the tongue on the incisive papilla. And based on that, you can see that the maximum opening is about 50 millimeters, the denominator. And when the tongue is on the incisive papilla, it's 38 millimeters. That gives us a ratio of 76%. And so the functional definition is asking, can the tongue tip reach the upper front teeth when the mouth is wide open? That's another way of thinking about it. And we came up with a scale to assess the severity of different tongue ties. And in this way, we're not saying yes or no, are you tongue tie, but we're saying how restricted are you compared to a population of other patients. Okay? And so if you're grade 4, we can tell the patient that your tongue mobility is in the bottom 10th percentile of the general population. If you're grade 3, we can say that you're below average, in the bottom 25 percentile. If you're grade 2, we say that you're average. We're not saying normal or abnormal. We're just saying relative to the general population. And if you say grade 1, you'll say you're the top 10th percentile. And we also appreciate that it's not only about the front of the tongue, but also how they are able to maintain lingual palatal suction. So we also can do these measurements with the tongue on the spot or while they're in suction hold. And so when you're doing these measurements, the tool was classified based on the tongue tip to the incisive papilla, and that was based on the lingual frenulum inspection protocols that Dr. Marquezan has published. But for some myofunctional therapists may prefer to measure it from the incisive foramen or just slightly behind that mark at the spot. And yet others may decide to do it while you're in suction hold. And again, this is a tool that we're using to describe so that we can assess the outcomes of our surgical releases. And so you look at this girl, and now we can say that she has a grade 2 tongue range of motion. We're not saying she's tongue-tied or not. We're not making that. We're not drawing the line. Because we're doing research, we're here to learn. We're here to describe what we're seeing. Then we can take it one step further, and we can say that she is able to get up her tongue, but she's doing it with extensive strain. And what you see here is that she's lifting up the floor of the mouth, and she's engaging her whole neck just to get up her tongue. And here's an example of a patient with just that kind of tongue tie. Let's get the audio up. Can we get the audio up? So you can see that it looks like a grade 2 tongue mobility, but really she's bringing up her entire floor of the mouth. And if we hold her floor of the mouth down, where it should be, and ask her to lift up, you can see. She can't get it up. She just cannot get up her tongue, and you see the dimple right here. That reflects the side of the frenulum attachment point. Good? Okay. Okay. And so stick out your tongue for us. Or lift up your tongue. Okay. Lift up the tongue to the front 2 teeth. Okay. So you can see that it looks like a grade 2 tongue mobility, but really she's bringing up her entire floor of the mouth. And if we hold her floor of the mouth down, where it should be, and ask her to lift up, you can see she can't get it up. She just cannot get up her tongue, and you see the dimple right here. That reflects the side of the frenulum attachment point. Okay, and so this is what we're seeing in our patients with sleep apnea. They're having difficulty getting back up the back of the tongue, and they're having to compensate with their neck and the floor of mouth muscles. Okay, and so what we did with this patient is we put her through myofunctional therapy and tongue tie release. And here's her baseline sleep study on the left, showing an apnea-hypopnea index of 26.86 events per hour, and her post-op results showing 9.2 events per hour, showing improvements in the apnea-hypopnea index, the respiratory disturbance index, the oxygen levels, and time spent below 90% oxygen, improvements of about 65 to 80%. And so we'll look at another patient. So here we are. We're going to demonstrate in our lovely patient grade 4 compensating to grade 2 tongue tie. So first of all, open up and lift up your mouth, lift up your tongue. So she's able to lift up all the way, but she's pulling up her floor of mouth and she's straining a lot with her neck. You can see all this tension in her neck just to lift up the tongue. This is because the tongue, relax now, is physically tethered to the floor of the mouth, and she's not able to lift up her tongue with the intrinsic tongue muscles. So she has to use all these muscles in her neck and in her jaws, and this is contributing to her chronic jaw pains in this example. Thank you for sharing with us.
Thank you.
And so when you can't use the tongue muscles, you have to compensate. You have to compensate by using the masseter muscles and the sternocleidomastoid muscles, the trapezius, just to get up that little piece of tongue tissue. And what we're seeing in a lot of our patients is that they come in with myofascial referral patterns of pain. And this is a infrared thermography of one of our patients who she moves her tongue and she's engaging her neck. So when we're examining our patients, we're looking for the tongue mobility, but we're also just kind of looking at the neck. You put your hand on the neck, and if they're really straining, they're not having a functional mobility of their tongue. They're compensating for it with the accessory muscles. And so when we evaluate a patient in our clinic, we start by evaluating them as grade 1, 2, or 3. And then we ask whether or not a compensation pattern is present. And we kind of demonstrated a few of the ones here. And so other things we can look for is the Eiffel Tower presentation with tension on the attached gingiva, floor of mouth elevation, cervical neck engagement, incomplete lingual palatal suction, and other issues that we can go into more detail for those who are taking our course on Sunday. And so we take a look at this case, and we'll ask you to assess the tongue mobility here. And so yes, she's able to get up her tongue beyond 50%. But if you take a closer look, you can see that she's pulling up her entire floor of the mouth here. The floor of the mouth should be down here in the floor of the mouth. She shouldn't have to be straining with her entire neck. And when she moves her tongue, she used to use her jaw in order to move her tongue from side to side. And so here's another example. And lift up your tongue. And then here's the frenulum restriction. She's lifting up the floor of the mouth here. The floor of mouth should actually stay in the floor of the mouth here. Now lift up your tongue. So that's all the mobility she has really in her tongue. Let's take it off without the light. Lift up your tongue. She really can't do it here. Lift up. So lift up your tongue again here. So right, so this should be here. Lift up. So she has a grade 4 compensating to grade 3 tongue tie. So it's pretty severe. Do you see that in yourself?
I do, but I always think mine's not that bad because I can stick my tongue out.
Right.
My dad couldn't stick a tongue out at all.
So we talk about anterior tongue tie, but posterior tongue tie is when you get the back of the tongue up. And you cannot get the back of the tongue up at all.
Wow.
And that affects the way your face develops, and it can cause a lot of... Okay. And so if we take a look at this example, it looks like a grade 1, but he has a lot of extensive strain. And if we control for the strain, you can see it's only a grade 3. And here's another one where he's a grade 3 compensating to grade 2 with the extensive strain. And in these patients who have this problem, if you touch underneath the floor of the mouth, if you just touch it gently, they jump from tenderness because it's so chronically strained in that area. And so what we're talking about is that the fact that the tongue, you want it to fill up the entire palate, and it's not only about the front of the tongue, but also about getting up the back of the tongue when we're talking about sleep and breathing issues. So this description, this vocabulary, allows us to differentiate between variations of tongue tie. And you need to be able to study each one individually if you're going to do a big study. You can't compare the grade 4 tongue ties to the grade 2 composite and grade 1 tongue ties. You have to study them all individually. Because if you put all that data in the same pool, they'll all average out and you don't really know what you're looking at. And so just because a patient may have one of these compensations or these functional issues, we have to realize that these variations are quite normal and quite average in our society. And the only time we're really going to intervene with a surgical procedure is if there's a tongue tie and there's symptoms. Okay? So just because you have a compensation pattern, you may be compensating adequately. You may be breathing and sleeping and functioning just fine. And we're not talking about prophylaxis in this case. Okay? Prophylaxis, we have evidence for grade 3 and 4 because it can cause a 6 to 10% chance of maxillary deficiency. So you can say, hey, if you have that severe, there's some chance that you can have underdeveloped maxillofacial skeleton. Yes, we can intervene prophylactically. But for these other compensating forms, these are treatments that we're trying to advance. And yes, these are case reports and case series, level 5 and level 4 evidence. But this is the pathway we have to take so we can learn more. And we want you guys to look for these signs in your patients so that you can help contribute to the knowledge base. What are some of the issues that you can find in these patients? You can have speech and swallowing issues, of course. You can have tightness around the base of the skull, neck, or hyoid from the chronic tension in these areas that they have to do to get their tongue up and to swallow. You can get neck pain, headaches, tension, clenching, grinding, sleep bruxism, reflux, heartburn, digestion issues from poorly chewing the food or swallowing air when they're eating, as well as sleep and breathing issues. And so yesterday we looked at this case study of this patient with incomplete prior frenectomy, and we saw how much she improved after the procedure. And so we'll take a look at her pre-op and post-op. You know, you're not really seeing the severe tongue tie that you might expect, because she is compensating for it because of problems with her posterior tongue tie. And so that's just one case, and so here's another. It's a 55-year-old female with head and neck tension, poor sleep quality, TMJ cervical neck issues. She can't sleep very well, and she had 2 prior sleep studies that were negative for the presence of sleep apnea. So this is a case in which we're talking about upper air resistance syndrome. And you can see she's able to get up her tongue, but she's really straining the floor of the mouth. And so here's what she was like during the procedure. We're releasing the myofascial elements.
Wow.
What's going
I can
on?
breathe.
You are able to fly now.
Oh my God.
Listen. Let's put the stitches and then we can talk. Okay? All right. Open.
I feel free. I have a capacity to breathe, to take in not just air, this sounds really corny, but life in a way that I couldn't before. I wish that you had been on before, but when he cut, I felt a release in the back of my neck, in the back of my skull, where my neck and my head meet. And I felt it down through my neck, all the way down through my core. And it was a complete and total release of tension, of pain, of a lifetime of holding on. And I feel completely relaxed. I feel safe. Wow, I feel safe. And I feel comfortable and at ease in my own body and in my own skin in a way I never have before.
Okay. So we have a lot to learn from our patients. So when we see these kind of changes, we want to study them very carefully and very in depth. And when patients tell us this one time, it may sound a little strange, but as you keep hearing the same thing over and over, this is where the evidence basis is being generated. The case reports to the case series. And then you can come together and you can kind of share it with your colleagues and sit and ask them, what do you make of this? And so when we share this with our craniosacral therapist and our physical therapist and our fascia specialists and our osteopaths, they're sharing with us that the tongue is intimately connected with every organ of the body, down your chest, into your diaphragm, and down into your toes through a network of fascia with the deep front line. And so when you release the fascia underneath the tongue, you're actually affecting all the fascia system in the diaphragm. And these folks are so tight and strained. Anytime she wants to move up her tongue, she has to bring up her neck, or she has to lift up her chest. Okay? And when you release this, you just created a lot of space and opening for the posture and the breathing. And so here was her pre-op. You can see that she's straining with the floor of the mouth, and then we settle the floor of mouth in. And she's getting a much better suction with her tongue. And so there's another case that
Okay,
I would share with you, but I'm going to have you guys see this on our website, who talks about the same kind of an issue. And here is this patient's pre and post. And this patient talks about the euphoria she experienced and the dramatic changes in her sleep and breathing. And if you're interested in seeing that video, we'll show it at our course, or you can go on our website and see that testimonial. Okay. And so when we're talking about tongue tie releases, the traditional standard of care is to only do a mucosal release and not to get into the posterior, right? And what we're finding is that there may be some benefit to going more posterior and deeper in some cases to support the myofunctional therapy. Very controlled. So when I first started doing these cases, we saw the traditional standard of care was just to make a cut and really not support it with any postoperative myofunctional therapy care. So you've created an improvement, but you've also maybe created a fixed scar because they didn't go deep enough. And other times where you're just going far, far, far too deep because they're trying to get a complete release. Okay? And it's really, really important that when we're doing these, you first want to do no harm. Okay? So here is a gentleman who had a deep release And he didn't do any pre or post-operative myofunctional therapy, and scar down. And this case as well. On this case, I asked no pictures on this case, but the rest you can. It's a little baby who had a questionable, maybe anterior tongue tie. This individual went in, I'm not sure how or why, or if they understand the anatomy of this region, and the child is left off worse off. Okay? So when we see reports of editorials published in the Journal of Pediatrics saying that there are providers out there butchering our patients, yes, it's true. And I nod and I agree with them. Okay? Because if you're going to do this work, you have to follow up your outcomes 2 weeks, 2 months, 6 months, 2 years. Make sure that what you're doing is actually doing what you think it's going to do. Okay? And so right now where we are is in a state where you cut and you don't know what's going to happen. And so when I started doing these procedures in fellowship, we knew that myofunctional therapy was important. We knew that primary intention healing could benefit the wound healing, but even I was getting suboptimal results. Okay? And so this is one of my early results in which I released the tongue tie, but I had some postoperative scarring. And the patient said, overall, it's really great. He's happy, but I feel a little snag when I roll my tongue over my teeth. It's becoming less of a problem, but I thought you would let it know. And so we find this as an opportunity to learn and even further improve our results. And so what I did is I paired up with my myofunctional therapist, Sanda Pinkerton. Sanda, are you in here? So Sanda, will you stand up, please? Yeah. Okay. And then with the help of Layli Noruz, who's our managing director, we developed a team to carefully study each and every one of these patients together, pre-op, during the procedure, and post-op. And so what we do is we see the patients beforehand, 1 to 2 weeks, up until 2 months. Even if they're doing well at 2 months, we then call them for a survey at 6 months, 1 year and beyond, so we can see how these folks are doing, not only a few days after, but really in the long term. And by doing that and having that data, we've been able to refine our surgical technique. We understand how deep we can go, what's too deep, when is it okay, what kind of sutures to use, what happens if you don't use sutures, what are the best kind of wound stretches and exercises, and that's the knowledge that we're hoping to share with you and also learn from your experiences as well so that we can further improve our protocol as well. Because we really have to understand each and every one of the variables in order to have an optimized, guaranteed result. And so here's this patient who had the mumbling, unrefreshing sleep and mouth breathing, and now we're able to effectively release the tongue tie and get really nice healing at 9 months post-op with improvement of the suction that we're seeing here. And we're also able to do revision procedures, and I'll show you, for those who take our courses later, some of the more extensive revision procedures that we do. But here was this patient after the first procedure. We excised the scar and able to optimize his wound healing. So how do we do it? The first goal is to restore mobility, and the second is to optimize wound healing. To restore mobility, in our practice, we excise the frenulum or prior scar tissue, and we do a release of the mucosal lingual frenulum up into the median lingual septum. Okay? In some cases, and only in some cases, we carefully choose these cases, we go deeper. And when we go deeper, we're going into the genioglossus muscle. When you go into genioglossus muscle, this is no longer a frenuloplasty. This is a partial genioglossectomy. Okay? And we'll show you how and when we do that. We don't recommend that you do this unless you've been trained and you understand specifically why you're doing it, but we just want to show you what's possible so we can advance the field. And so here's the genioglossus muscle, and I'll show you that in some cases it is beneficial to actually go into the muscle and release it. And there's different ways of doing the procedure, but no matter what, we want to minimize scarring due to indiscriminate use of cautery. And so our preference is for the scissors and sutures technique. I'm a surgeon. That's the way I was trained. We know that there are providers who can do a very nice job using a laser, okay? And we endorse however the person's going to do the procedure. These are just tools that you're using. It's more about the technique. And the technique requires you to be very gentle and cut only the fibers that you need, understanding that indiscriminate use of cautery is going to cause a lot of scarring. And so personally, I prefer the scissors and sutures because I can get into the muscle, and I personally find that if you use a laser cautery into the muscle, you're causing it to contract more. And so that's why I prefer that. There are providers who use the laser technique and use blunt dissection to get the deeper, and I find that that's perfectly adequate. And so in our language of talking about what we do, there's frenotomy. And frenotomy is when you incise the tissue, either by cutting or ablating. You're making a cut. Frenectomy is when you're actually removing frenulum tissue. So if you're not removing tissue, you haven't done a frenectomy. You've done a frenotomy. Frenuloplasty is when you use sutures to repair the overlying mucosa. And we find that when you put the sutures, it allows for smoother primary intention wound healing, as we may hear later on today about the different kinds of wound healing, and the scar line is minimized. We then talk about revision frenuloplasty, and a revision is when you had an unsuccessful result, and you want to go in to do a further procedure to restore that mobility. We distinguish that from stage frenuloplasty. There are some cases of grade 4 tongue tie that's so severe. In those cases, we release the anterior tongue, just the mucosal elements. And then in a second stage, we go deeper into the genioglossus muscle if necessary. And we distinguish that for research purposes. So, a priori, you're saying that you're going to do it in 2 stages. That's different than doing it once and then revising your result. Risks of surgery are pain and soreness for 3 to 5 days. You see a lot of soreness in the throat and the muscles in the neck here, and that's why we endorse the use of craniosacral therapy, physical therapy, osteopathy, fascial therapy to help support the patients. They've been suspending all the way in the front, and as you release this, all the pressure now goes in the back, and they're going to be sore, and we want to support our patients through that process. Swelling and inflammation is normal. You may develop occasional mild wound infection, granulation tissue, bleeding or bruising, numbness of the tongue tip, which is in less than 1% of patients and usually comes back by about 6 months' time. Potential for scarring, no improvement or worsening, a need for revision surgery. In our practice, myofunctional therapy is essential to optimize the outcomes because the dissection is a lot easier, and I hope to share that with you in one of the cases that you'll see. You'll see that when the tissue is optimized, you don't have to do a lot of cutting. You can just touch the tissue very gently, and the tissue itself will separate. Okay? And I'm going to demonstrate this with you in our cases. And so just very, very basically, what is this? The myofunctional therapy is a separate thing that we have to consider. You want to get the tongue toned and strengthened and get it up to the roof of the mouth. You want to identify compensations in the way that they're moving the tongue and make sure the patient understands that. And then the postoperative therapy will help them rehabilitate. I just want to show you, because I only have about 15 minutes left, how we do our surgery technically. And so we start with just topical anesthesia. We inject with 1% lidocaine with epinephrine. I place a groove director over the sublingual glands. I use a hemostat to clamp along the mucosa distal and proximal to my incision site. I go ahead and I make a frenotomy, a cut, and then I do a frenectomy. I cut out that mucosal tissue. I then identify the median lingual septum. The median lingual septum is a piece of fascia, myofascial tissue that runs between the 2 heads of the genioglossus muscle, and that completes my mucosal frenuloplasty. Sometimes I go deeper, and I'll show you what that looks like. That is now a partial genioglossectomy. Here is the restrictive myofascial band. I isolate it very carefully. I make 1 cut, and that's it. And then I suture it up for primary intention healing. Okay? Allow me to show you a case of a child who we operated on. Okay? We put him through myofunctional therapy beforehand, and this in and of itself will improve the presentation of the tongue tie. So a lot of times they'll come as a grade 4, you put them through therapy, and now when you measure them, they're a grade 3. You start with a grade 3, they'll be a grade 2. Okay? But we find, and he's able to hold his suction here, but we find that if you do the procedure, they're able to hold the suction with much more fluidity and ease. So much so that they actually have to put some effort in getting the tongue down. And so when I'm doing the procedure, it's most ideal if the patient is able to do it while they're in the suction hold, because then I can very clearly see which fibers it is that's holding down the tongue and target only those fibers. Good. Suction up. Suction up. Okay, very good. All right, tell me if you feel this. Open up real big. I've already numbed up the tongue. There's my clamp. How about here? No? How about here? Very good. Swallow for me. Lift up. Lift up your tongue. Lift up your tongue. Open up real big. Good, you're doing great.
That on Earth actually kind of hurts when I do that.
Lift up, lift up.
Boys, that's a big one.
Very good.
Giddy up, posse. Just one more today. Wow.
Okay.
Let's face these asteroids.
So that's the frenectomy.
Push
and swallow.
Big or small.
Can you recline them a little bit? Sure. Open up for me. Open up real big. Open up real big. Show me your cave. Okay, very good. Clint. Okay, this is the median lingual septum, that piece of fascia tissue. And this completes the posterior tongue tie release, okay? That a lot of people talk about. It's just the fascia that we're cutting here. Until you can see the two heads of the genioglossus muscle. You're doing great, and then you go in there with, and just blunt dissection to release the rest. Close your mouth. Close your mouth. Minimal to no bleeding because the tissues have been adequately prepared. Feeling, right? Lift up your tongue. Good. Lift up. Good. You can see some a little bit of the restricted fibers in there. Lift up. I'm feeling, I'm palpating. Good. That looks good from there. Stick out your tongue at me all the way out. Good. Straight. A straight chin. Are you numb here? You feel this or no?
No.
Open up. You did great. Okay, lift up your tongue. Lift the implant. Good. You want to check it out? Yeah, it's okay. A little marking. Oh, you want marking? Yeah, marking. Push. Good. Open up. So good. Push. Okay, open up for me. Show me a cave. Very good. Show me a cave. You're doing great. Lift up real big, real big, real big.
Now word spread fast and he got all scared. He'd be better off by avoiding
Are you feeling these?
if he'd stayed.
Don't swallow. Don't swallow.
That could be the way.
Another guy. Open up. Push. Stomach. Which one? No. Open for me. Lift up your tongue. Lift it up. Cave for me. Cave. You're doing great, okay? Very happy with what I'm seeing. You're doing great. Are you feeling this? And I suture it up in the same way. Thank you. My favorite one. And when I do the sutures in this way, it doesn't put a lot of tension on it. Open up real big for me. And you can see the tongue is suctioning up a lot easier now, a little bit less tension. Come for me. Sure. Grab. I'll just fast forward the suturing just a little bit. Stick out your tongue for me. Stick out your tongue all the way out. Stick your tongue out. You're approaching like a final wound here. See how you have to break the suction? And by bringing the wound edges together, you allow it to heal with a very small scar line, as opposed to the diamond that has to kind of pull in and that you have to stretch. And so here we don't do any manual wound healing. We just mobilize the tongue and have them hold it in suction, and that's the post-operative myofunctional therapy. Okay? So I only have about 10 or 11 minutes left. Sometimes, so this was primarily anterior. I didn't really get into the very posterior genioglossus muscles. There's different vocabulary that individuals use to describe anterior versus posterior. Dr. Gahiri, this is a slide from Dr. Gahiri, and he explains that you have the mucosal frenulum, okay? And then there's this band of the median lingual septum right here. And Dr. Gahiri describes this band as the posterior tongue tie, okay? And what he sees is that a lot of people just cutting the mucosa because they're afraid of getting like bleeding and issues like that. But if you and he advocates just going a little bit more to freeing up that fascia. And that's what he considers an anterior versus posterior tongue tie. In our experience, when we talk about posterior tongue tie, you could use this vocabulary, but the vocabulary we're using is whether they're able to lift up the front of the tongue or not able to lift up the back of the tongue. And so for those cases in which they're having trouble with the back of the tongue, we do find that it's necessary to sometimes make an incision in the superior myofascial fibers of the genioglossus muscle, and I will demonstrate that to you in this case. Okay, so you take a look at this case, and you're like, where's the tongue tie, right? So this is a grade 1. And I'm demonstrating this just to advance the care. I'm not advocating that you guys do this. I'm just doing it as a case report. So we start by numbing up the tongue. Is the audio on for the video? Okay. Hope you got on time. Can we turn up the volume on the audio? So now we're doing partial genioglosectomy in this case, okay? Partial genioglosectomy we do not advocate with cautery, just with scissors if you're going to do it. So that was a frenotomy. You could stop right here if you're just doing it anterior. That's all you need to do. You're seeing the two heads of the genioglossus muscle. You leave it at that. If you're going to do a frenectomy, this is how you would do it. Okay, what you're seeing under there, that muscle, is the genioglossus muscle. Okay, that was the frenectomy. We're done with the frenectomy.
Okay. Go ahead. Open up. We need to take a pre-op picture. Just from your shape. Great.
So these fibers are deemed to be restrictive. So I make a clamp,
Straight.
and where it blanches, just where it blanches, make a cut. And as we're doing that, the tissue's separating. Do you see that? How the tongue's just lifting, the fibers are just separating? You can see that the fibers are still restrictive. They're still bearing down the tongue, like a heavy backpack, forcing it down, like an anchor.
Relax. Close. Clamp.
Watch this step very carefully. No cutting here. Clamp the tissue, and look what happens. It just separates. Okay?
Q-tip.
And so this is why the myofunctional therapy is important. And this also tells us, it confirms to us that those fibers were restrictive. Just a small tug, is all that you need to release it. We're not cutting, we're just letting the tissue release itself. And we're trying to have like osteopathic principles of just getting the restrictions out of the way and letting the body do the release. We're not going in there to release the tissue. We're allowing the tissue to release. Okay? And I only have 5 minutes left, so I'm going to fast forward through this. This case is on our website if you want to see the whole thing. You go to Zaghi MD, you see the whole entire case. And we continue, and then we put stitches, and this is what it's looking like towards the end of the case, okay? So did we do the right thing, right? You get an email like this, and it says, "Hello, Dr. Zaghi. I wanted to let you know the experience was incredible. Truly one of the most profound experiences and outcomes of my life. This is just one of the few things I've noticed. Sleep has dramatically improved. I'm dreaming again. It's much easier to move air through my nasal cavities. I no longer need the breathe right strips. My nasal valves do not collapse anymore. My top teeth, for the first time in 20 years, since extraction, retraction, orthodontics, have come forward of my bottom teeth. Thank you for everything." Okay? So this is level 5 evidence. So what does that mean? Does that mean that you should do this for all your patients? No. It means that you're going to carefully select patients, and if you do this, you're going to collect variables and data points so that you can do further studies. Okay? So this is just the beginning of our research. And so here he is at 14 weeks post-op with very nice, adequately healing tissue. So I have another case that I don't have time for, but if you go on our website, you can see it. And it's a similar case that you guys can see how I do posterior tongue ties. And so here she is before and after with a very, very similar experience on the patient's behalf. Okay? It's important to talk about wound healing, and we're going to hear about that later today. We advise our patients that in our experiences, from pre-op to 1 week, they're doing okay. From 1 week to 1 month, the wound will always contract. Okay? And from 2 to 9 months, the wound will always release. So if you're ever going to do a revision, wait. There's no urgency because all wounds will contract no matter how you do it. And after 2 months, it'll start to release. So if you do an incision, they're doing okay at 1 week, and then around 2 or 3 weeks, it's starting to pull in, reassure the patient that the natural process of wound healing is remodeling. It's going to release. Wait till 2 months. Wait till 6 months. Wait till 9 months. See how it evolves. See how it evolves with manual therapy before you go in and doing 2, 3, 4 procedures. Okay? I want to thank you guys for inviting me to speak here today. I really enjoyed the audience and the group. You really have some really advanced participants here and a really great lecture series, and I'm really proud to be affiliated with you guys. I look forward to seeing the others of you who are joining us for our deeper look, where we're going to spend about 8 hours going through all the things that I mentioned and highlighted in this lecture. And I also want to encourage you guys to join us at the 3rd AMS Congress in Rome. This is an opportunity for people from different backgrounds to come and share their knowledge and experience so that we can further advance this field and do important work. I thank you guys very much.